hemodynamic monitoring. So the objective of this is pretty straightforward. We're just going to compare the various methods of hemodynamic monitoring. It is performed by using a pressure monitoring system to measure cardiovascular pressures. The primary goal of this monitoring hemodynamics is to gain information on cardiac output and perfusion. It is to maintain adequate tissue perfusion by assessing the body's response to tissue oxygen demands, alert the healthcare team of impending cardiovascular crisis before organ injury occur, and evaluate immediate response to treatment modalities. Using non-invasive and invasive methods can provide quantitative information about vascular capacity of blood volume, pump effectiveness, and tissue perfusion. So some non-invasive methods would be like using a blood pressure cuff and items like that. More invasive, obviously, would be like your central venous catheters, your pulmonary artery pressure, and your intra-arterial blood pressure monitoring. So, and the monitoring, the components of a hemodynamic monitoring system include a disposable flush system, a pressure bag, a transducer, and an amplifier to monitor. By performing and introducing a central venous pressure, pulmonary artery, or arterial catheter into the appropriate blood vessel or heart chamber, it ensures the system setup is maintained properly. It needs to be kept at the patient free of air bubbles. Checking position of a stopcock and transducer is properly positioned before pressure measurements are obtained. That level is actually called the pulvitic axis. Like I said, this is kind of more of a upper level nursing thing that is trained primarily for ICU nursing, but it's good to be aware of what's going on with it. They do receive special training to be able to manage this system. Leveling it, the pulvitic axis is an anatomical area which is used to level the stopcock. The pulvitic axis is located in the fourth intercostal space at mid-axillary line. It is the location of the right atrium. Best practice is always using a leveling device. They don't eyeball the pulvitic axis when leveling. A lot of times they'll use a laser pointer that's attached to the IV pole, and then with that, that's how they're able to shoot a straight line to make sure it's always in the right spot. They'll mark the patient's axis and use a laser pointer to find exactly where it needs to be leveled on at all times. Here's just kind of a picture on where the pulvitic axis is, and the different angles of where the patient is at, where the pulvitic axis actually lies. So when zeroing this, the zeroing is a reference point established to ensure that the system properly functioning at atmospheric pressure. After leveling the transducer to the pulvitic axis, open the transducer to air and activate the zero function on the bedside monitor. This is just make sure everything's at the base levels. There are some complications. It's the risk of a pneumothorax, infection, air embolism, and like any central line or any IV in general, after 72 to 96 hours, there is the risk for infection, and it increases the longer the catheters are in place. Air emboli can be introduced into a vascular system if the stopcocks are attached to the pressure transducers are mishandled during blood drawing. So like remember how if you haven't, when you're priming tubing, you always make sure all the air bubbles are out, and those are probably some things you do, especially in something as delicate as central monitoring like this. So the most common preventable complication is catheter-related bloodstream infections. You might want to review table 25.5. That's just the interventions to prevent intravascular catheter-related bloodstream infections. So a lot of this, if you look at it, a lot of this is going to be standard care for all central lines, aside from like the specific pressure monitoring system and those things. So it is good to review this because this will help you with basically all levels of central line care. So you've got different, we got central venous pressure monitoring. This is a measurement of the pressure of the vena cava, the right atrium. It measures at the end of diastole. The pressure of the vena cava and the right atrium and the right ventricle are all equal. So the central venous pressure also reflects the filling pressure of the right ventricle. So that's measuring your preload. The normal central venous pressure is 2 to 6 milligrams of mercury. Anything higher than that can mean elevated right ventricle preload. So if you think about what can be causing right ventricle preload, could be elevated hypervolemia, right side heart failure, or excessive fluid circulating through the body. So that's some things that can cause it that way. And then common cause of low central venous pressure would be the reverse of that. You got your hypovolemia, dehydration, excessive blood loss, vomiting, or diarrhea, or overdiuresis if they're give a little too much Lasix too often, or over treating. Preferred site is going to be your subclavian vein. It's a sterile procedure using local anesthetic. It's just like a central line that's being placed. Physician threads the catheter. It can be a single or multi-lumen catheter. A lot of that depends on what the size of the vein they're actually inserting in. A larger vessel can handle a little larger of a line. Generally, they'll try to use one that has multi-lumen threads, just so that they have the ability to give different medications and different ways to monitor. Pulmonary artery pressure monitoring is used to assess left ventricular function, diagnosing an etiology of shock, evaluating a patient's response to IV fluids. Or you're going to say if you're giving fluids, you're going to be able to monitor if the levels if your pressures are within range or if they're high or low still. Pulmonary catheters and pressure monitoring systems are used. Various types of catheters can be used and can have ports for temporary pacing, oximetry, cardiac output monitoring, or a combination of functions. So depending on the line you're using, they have different functions. So they can have one that has a pulse oximeter, so you can tell your oxygen saturation as it's entering the heart, or you can tell different pressures in different spots of the heart. So the pulmonary artery pressure monitoring catheters are balloon-tipped, flow-directed catheters that have distal and proximal lumens. So the distal lumen is a port that opens into the pulmonary artery and is used to measure pulmonary artery pressure. So what it's kind of doing is, what it'll do is, rapidly they'll inflate this lumen, and they'll be able to measure the amount of pressure of blood behind it, and then they deflate it right away. That's just a way for them to see what kind of pressure is coming behind it to help with your pulmonary artery pressure. And then you got your proximal lumen. The port opens in the right atrium, and that's used to administer IV fluids and medications. It's used to monitor right atrial pressure. So, it's a good spot if exactly for those reasons. Each catheter has a balloon inflation hub and valve. A syringe is used to connect the hub. Used to inflate and deflate balloon with air. 1.5 mils is the max volume. During insertion, when the pulmonary artery wedge pressure is being measured. So the pulmonary artery wedge pressure reflects the level of ventricular and diastolic pressure. So normal pop is 8 to 12, and you don't, just a tip, don't fill the balloon with fluid. It's used air only. So the trick with it is inflating the balloon tip causes it to float more distally in a smaller portion of the pulmonary artery, and then it's wedged into position. So this is a occlusive maneuver that impedes blood flow throughout that segment of the pulmonary artery, and the wedge pressure is measured immediately, and the balloon is deflated promptly to restore flow. Kind of we talked about earlier. It blows it up, it blocks the flow, and it's able to measure the pressure behind it, and then they deflate it right after it. So here's a quick image of what we're looking at here. So like I said, there's several different ports we talked about. So you've got your balloon valve inflator. This is down here. You have a proximal infusion port, and then you've got a distal lumen for distal lumen infusion. Nice thing about having different lumens is if a medication isn't compatible, since you have two separate locations where the medications are being infused at, you can actually give them at the same time because of the mixing of the blood. So it's a good way, it's just a way to be able to manage multiple medications. Like I said, pulmonary artery wedge pressure monitoring is preferred sites of subclavian vein. The pulmonary artery catheter is covered with a sterile sleeve and inserted in a large vein through the sheath. Insertion techniques and protocols mirror those used for inserting central venous pressure catheter and like we talked about earlier. Catheter is then passed in the vena cava through the right atrium. The balloon tip is inflated in the right atrium, and the catheter is carried by blood flow through the tricuspid valve into the right ventricle and through the pulmonic valve, and then branch to the pulmonary artery. So I thought it's kind of cool, because then it's basically using the balloon and the blood flow to actually pull it to where it needs to be done. And then when the pulmonary artery, in the pulmonary artery, the balloon is deflated and the catheter is secured with sutures. So fluoroscopy can be used during insertion to visualize the progression of the catheter through the heart chambers to the pulmonary artery. So that's just how they visualize to make sure it's actually placed properly. Quick just picture of the transducer being attached to the line. So here's kind of what we were just talking about. So you have your monitor. You got a pressure bag that keeps constant pressure on the line to stop blood flow from flowing back up into it. And then you've got your sterile sleeve, and then you've got the line goes into sphere vena cava, and then once it gets into the right atrium is where you're gonna inflate it, and then actually your blood flow will pull it through all the way up into the pulmonary artery, where it'll be stitched in and held into place. There are going to be some complications, pulmonary artery rupture, pulmonary thromboembolism, pulmonary infarction, catheter kinking, dysrhythmias, air embolism. So, all those things. When you're sending you're sending a line through the heart. There's several complications that can happen while you're doing it. Intraarterial blood pressure monitoring can be used to obtain direct and continuous blood pressure measurements. When ABGs or measurements or blood samples are needed frequently. So that's nice if you have a patient that needs frequent arterial blood gases. If you have an art line, you can pull them off easily without having to poke the patient each time. Usual site is the radial artery. Just keep in mind, placement of the catheter in this area can impede perfusion into the area that has poor circulation. So anything distal to the cannulated artery can become ischemic or necrotic. So you're going to be doing a lot of key thing with that is if you have someone with an art line, you're going to be doing assessments distal to the insertion site to make sure they have good perfusion, good cap refills, and make sure they don't have any tingling. The usual assessments. There is a specific test you can do to see if proper before they even do it. They'll do it. It's called the Allen test. It's to find out if the blood flow is even optimal enough to have a central an arterial line placed there. Basically, the hand is elevated and then asked to make a fist for 30 seconds, and then you're going to compress the radial and ulnar arteries, causing the hand to blanch. After the patient opens the fist, you release the pressure on the ulnar artery, and the radial artery is still compressed. If the blood flow is restored and the hand turns pink, within 6 seconds, the circulation hand is probably adequate. So here's just kind of a quick visualization to see how the hand is, it's blanched, and then now it's returning color to it. So that ring looks really tight right there. I don't know if I'm the only one that sees that or not. So the Allen test, if it's normal, the hand becomes warm and returns to normal color. This means that the one artery alone will be enough to supply blood to the hand and fingers. If it's negative, the hand's going to remain pale and cold. This means that one artery is not enough, and you'll have to go to a different source to collect arterial blood. So some serious complications you can have, like I said, we talked about the obstruction of distal ischemia, excessive hemorrhage. You are tapping into an arterial line. If that line becomes dislodged or comes out, you could have a risk of a lot of bleeding, massive ecchymosis, dissection, air embolism, blood loss, pain, infection. And that sums up the monitoring. If you have any questions, you're welcome to reach out. Here's my email address and access to my calendar. Look forward to seeing you guys at lecture. Thanks a lot.